4, 3, 2, 1. We are live.
Hello. Hi. Thank you for coming to this online webinar program. It's our 4th APSS webinar session. And the theme for this session is spinal trauma, cervical trauma, and thoracolumbar spine trauma. So without any delay, I would like to ask Professor Rajaskaran to make the welcome address.
Yeah. So thank you very much, Chee, and welcome to all of you for this 4th in the series of webinar programs of the Asia Pacific Spine Society. I'm really particularly happy and feel privileged that our organization has done so much and taken it up as a challenge to do so much of educational activities even in these times of COVID. So as the saying goes, when the going gets tough, the tough get going. And even in this period of COVID, we have harnessed technology and not been laid back on educational programs. For these, I would like to actually congratulate our educational section chairpersons, Wong and Vishal, for taking up a lead on this. And congratulations, CC and Vishal, for doing a great job for APSS on this. Today's webinar is actually something which is very relevant to the entire Asia Pacific region, because spinal trauma is still rapidly on the increase, especially in the developing nations. And there is a lot that the training persons and the young spine surgeons are faced with every day. And I'm sure that this program will be a great boon for them in their knowledge. So the moderators will be Kwan and Chek. And I'm glad to see that there is a wide galaxy of eminent speakers from all over the Asia Pacific region. And also glad that Singapore Spine Society as a guest nation is also having a special focused time on this. Glad to see Gabriel, Jacob, and Dinesh on the panel. Congratulations to all of you. And I would also like to thank Newasive for sponsoring this very important event. So without much ado, I would like to hand over to CC for taking up this program. Thank you.
Yeah, the next item will be program overview by the chairman of APSS Educational Committee, Professor Wong.
Thank you, Chikit. Welcome again to this afternoon's APSS 4th webinar. And this afternoon, we have a 2 hours session on spine trauma. We will have on the first part, the cervical trauma, which is with 3 topics, and we will have a discussion, following which we will have the second session on thoracolumbar trauma. And then we will have a special guest nation session, this time from the Singapore Spine Society, also on certain aspect of the spinal trauma. This afternoon, we will start off with Dr. Rohit from Nepal, from myself and Gabriel on the topics you can see on the screen. And we will have some discussion following the 3 presentations, and the presentation will be facilitated or moderated by Kenny and Chikit. And following which, we will have the thoracolumbar spine trauma by Dr. Arif Khan, Dr. Pankaj, and Dr. Chhabra from New Delhi. Again, after this session, we will have a discussion. And this is a very interesting topic to most of us. So I think we will have a lot of discussion, and Kenny and Chikit will have a tough time trying to have everybody's question answered. And following session 2, we will have the guest nation session, which is by Singapore Spine Society this afternoon. Thank you to Gabriel who put this thing together. Welcome Dr. Dinesh Kumar, Dr. Jacob O, and Gabriel to have this session with us. I would now like to invite the speakers for the cervical session to get ready, and hopefully we have a very nice afternoon of learning together. Thank you.
Thank you, Prof. Wong. I think we will continue with the next session, which is the first session. I'll pass over to the Kenny Kwan to introduce the speakers from the first session.
Okay, well, welcome to today's webinar. We have a very nice program for you all. So the first session is going to be on cervical spine trauma, and I would like to introduce Dr. Rohit Pokharel from Nepal to talk about the SLICS classification, decision-making in cervical spine trauma. Please, Dr. Rohit.
Thank you very much, Education Committee of APSS, for giving me this opportunity to talk on SLICS classification decision-making in cervical spine trauma. As we know, cervical spine joins the cranium and thoracic spine. There are 7 distinct vertebrae. Upper 2 atlas and axis are upper 2 cervical vertebra, and subaxial vertebra contains thigh vertebra. There are C3 to C6 are typical, and C7 is atypical vertebra, because it doesn't have vertebral artery and there is a long unbifurcated spinous process. If you see a typical cervical vertebra, then it has a small body, triangular vertebral canal, transverse foramen, facet and lateral mass, and bifid spinous process. The anatomy of the cervical spine, it protects, it covers the spinal cord, and it has a lot of vascular structures. They go to and from the brain. And then there's in the spinal cord, there are ascending and descending neural impulses. It is a very mobile segment of the vertebral column. The stability of the cervical spine is given by the muscles. They give the dynamic stability, and the bony articulations like intervertebral discs, fascial joints, and orthovertebral joints, they give for the bony articulations. And more important than that, the ligaments in the cervical spine, they give a stability to the spine. There are 5 ligaments, important ligaments like anterior posterior longicular ligament, ligamentum flavum, interspinous ligament, and supraspinous or the nuchal ligaments. Whenever we talk about the injury in the cervical spine, then we must know this space available for the cervical cord, for the cord. So this space is wider in the proximal and the distal part of the cervical spine. So if there is any injury in the mid part of the cervical spine, there is more chances of having neural injury. All trauma patients have a cervical spine injury until proven otherwise in the dictum that we know, and thus it should be immobilized in cervical part. Having said that, all may not have cervical injury and thus may not need any unnecessary further radiological evaluation and cervical immobilization. Cervical spine clearance has been given there. There are some criteria given by the Nexus and the Canadian Cervical Spine Rule to clear the cervical spine. Once there is a clinical radiological diagnosis of the cervical spine injury, then it's always helpful to have one classify this, and it helps in the communication management, prognostication, and the research. And then it depends on the classification, usually depends on the skeletal ligamentous and the neural damage. And whatever classification we use is easy, reliable, and well validated and basically speaking, there are certain mechanisms of the cervical spine injury like flexion, extension, compression, distraction, and there may be combination of 2 and more. Based on the stability of the cervical spine segment, there have been a lot of classification given over a period of time. The first spinal injury categorization was done by the Bowlers in 1929, and then onwards he suggested the column theory. Allen and Ferguson in 1982, they suggested they had a classification system based on the injury vector and the position of the cervical spine at the time of accident. Harris et al. In 1986, they gave another type of mechanistic classification. White and Punjab in 1990, they gave a checklist for the stability of the evaluate the stability of the cervical spine after injury. Anderson's in 2007 and spine trauma study group STSC, they suggested cervical spine injury severity score, and the first time suggested this score for theory. In 2007, Pokharel et al. And STSC group, they first time suggested this name subaxial cervical spine injury classification. The aim of this classification system was to standardize and quantify the injury severity. They gave a weightage score in the 3 parameters to give a threshold to decide for the treatment, morphology of the fracture, and the discology complex injury, and the neurological injuries. This chart, it gives a gross idea regarding this classification scoring system. Like morphology, there may be a compression, burst, translation, rotation, or distraction injury. You can see that the distraction has been given more score and followed by the translation and rotation injury. And this is morphology is based on the radiograph, plain radiograph, and CT scan. And there is discology complex, which is evaluated after the MRI. It is intact or suspected, or neurological examination is serious, and the physical examination with the neurology. The highest scoring is given to the incomplete cord, and if there is an ongoing cord compression, then we add 1. So overall total highest score is 10 out of 10. If the score is more than 4, then we always suggest for the surgical intervention. If it is less than 4, we can treat the case non-surgically, and if it is 4, it is a borderline. It's under the surgeon's choice. In this case, we can see that the burst factor is distraction. So there is a dislocation of the facet joints, and you can see there is a wide space between 2 spinal processes, suggesting that there is a ligamental injury. So the score is 3 plus 3 plus 2 plus 4. So there is incomplete neurology with the chances are more injury. So it's a 9. So we wait for the surgical intervention. So for morphological description of the injury in this classification, there is a quick validation and the agreement between the Allen's classification. For example, in the compression factor, it is the compression, inflection, and extension, stage 1 and 2. The burst factor is vertical compression, translation rotation is flexion, distraction, flexion, compression, extension, distraction, extension, compression, stage 4 and 5. And distraction is distraction, flexion is distraction in the extension. So severity of the injury in terms of neurological depth, it increases with the stage of injury. In another case, there is a translation injury at the level of the C6, C7, it's score 3. Ischemic injury is there, so it's seen in the MRI, it is 2, and incomplete neurology, so the score is 4. Incomplete neurology is 1 plus 1 is 4. So again, the score is 9. So we wait for surgical intervention posteriorly. So AO Spine Knowledge Forum, they have come up with this in 2016, they have come up with the AO Spine Selection Cervical Spine Injury Classification System, and they give some scoring. So the basis of this AO subaxial cervical spine injury classification system is the morphology of the injury, facet injury, neurological status, and any cases which is modifiers. In this chart is a comprehensive chart, it goes the classification system suggested by the AO. However, the threshold for to delineate the treatment of the treatment is not available. Pediatric cervical spine injury is pediatric cervical spine is more prone for the injury because of the more axial orientation of the facet joint, more anterior wedging of the vertebral bodies, more lax ligament, and the proportionately large head. So the classification has been given by the Mohd and Pokharel. They have divided into anterior column, lateral column, and the posterior column, and in special cases in the column injuries, they have divided into isolated and complex.
Yeah, we will proceed with the next presentation by Professor Wong on facet dislocation, approach to surgical management. Professor Wong.
Thank you, Chikit. Could you see my slide?
Yes, Prof.
Thank you. Yeah. Thank you again for the APSS to invite me to share with you on this topic of cervical facet dislocation, approach to surgical management. The clinical issue of a is basically one of a dislocation and neurological compression ongoing, and also instability, because as you have heard for the previous lecture, this is a soft tissue injury and the ligamentous are all disrupted. And probably the only ligamentous structure that is intact is the anterior longitudinal ligament in a bifaceted dislocation. So I will share to you this case one of the 31-year-old young man who fell from height in the workplace and immediately unable to move all his 4 limbs. And there were no other injury. And on your right, you could see his X-ray showing this malalignment of the cervical spine. And you could actually make out that there's a C4 and C5 dislocation. So this is the CT scan, and you can see that there is a C5-6 dislocation, as you have seen on the X-ray, and also a C5 lamina and spinal process fracture. And this is actually a good sign in some patients where the fracture actually widens the canal slightly, and patient suffer less severe neurological deficit. And I also choose this case to show you, look at the quality of the CT scan, which is much to be desired. And this is a situation not we have in the spine center and where we practice, but many a times this injury occur in places, in the remote places where this is the best you can get. And that will bring on to my next point about how we should manage this patient in the immediate period. So here we are talking about immediately we need to decompress the cervical spine. Here, there are many studies that say that as early as possible, you will give the patient the best chance of neurological recovery. Let's look at this key stasis study of a prospective cohort of 313 patients, out of which 182 underwent surgery, which presumably also decompressed the cervical cord at 14 hours after the trauma, whereas 131 had the similar procedure at 48 hours after the injury. So of these 313, only 222 are available for review at 6 months after the injury. And about almost 19.8% of the early surgery group had more than 2 ASIA grade improvement versus less than 8.8% of those who had surgery performed later. The complications are the same. And mind you, of these 182 who underwent early trauma, the significant improvement group are those with early reduction for cervical bifaceted dislocation. So in this situation, I would think that the earlier you can get the patient's dislocation reduced, that's the fastest, there's the best outcome from the neural decompression point of view. And I can say this is something that is quite easily performed. All you need is just scalp tongue and some pulley. And even if you do not have a pulley, you can still have some kind of weight system where you can apply traction. And I prefer you can do it next to the radiology department, because then you don't have to move the patient from the ward to the department, to the radiology department for repeated x-rays. And you usually start with a 5 kilogram of weight. That is roughly the weight of the skull and the head. And from there, we increase every half half a kilogram, it's actually not so much of time limit. Every time we put on the weight, we will do a lateral cervical X-ray, and if it's not reduced, we increase half a kilo, and then we repeat the X-ray again. And of course, at the meantime, you have to monitor for any complication. So this is that patient that I just told you about, and at 10 kilogram of traction, you could see that there's an opening up of the disc space, but the dislocation is still not yet reduced. So further increase of the weight is being performed. And at 15 kilogram, you could see now the cervical spine alignment is back to normal. Of course, there is still over-distracted disc space because the cervical spine is now under 15 kilogram of traction. So it's very important that at this stage, as soon as you reduce under using this awake cervical traction technique, then you should reduce the weight back to 5 kilogram maintenance weight to not distract this cervical spine with this heavy weight for too long. One of the questions we always ask is, what happens if we do this reduction and there is increase in the disc fragment prolapsing into the canal? Here, I would like to quote you a study doing MRI in real time while the cervical traction reduction is being performed. Here, this study reported on 17 patients and prospectively. So basically, what happened is when you apply traction to the cervical spine, you actually increase the disc space, and that increase in the disc space of the injured or dislocated level actually sucks in the disc fragment. So actually, you can see here, as the weight is being increased, the facet dislocation is reduced, and also the disc prolapse fragment is actually smaller. This particular patient, because it was being reduced in a facility from my hospital, and when he arrived, we actually performed a cervical spine MRI, and you could see that here, of course, I cannot say every patient, this patient do not have a disc prolapse of that injured segment. So when do we abandon this, right? If the patient reports worsening of neurology, or there's a skull tone avulsion, which can happen if the pins are not solidly anchored on the outer table of the skull, or we are not able to reduce even with 50% of the body weight of the patient, then I would suggest that we convert to surgical reduction. And the patient also not able to tolerate procedure sometimes, and even with some mild sedation, we will also consider this a failure of this technique, and hence perform surgical reduction. So I think this is the best technique you can perform in any facilities, not even in those facilities without spine surgeon, you can perform this. And once you reduce, then you can have the time you have to actually fuse the segment, because one of the problems is even after reduction, we are going to have a very unstable spine, and that is the mandatory reason that this patient need fusion. So if the close reduction is successful, then I prefer to perform anterior surgery, because anterior surgery is less traumatic, and I can also insert a lordotic bone graft to ensure the segment is lordotic, and to use a locking plate system. So basically here you can see my mistake of using a non-locking plate system where the dislocation reoccurs. Likewise, you can also perform posterior stabilization, like what you've seen here. There are many examples. You can even use pedicle screws to actually stabilize the posterior cervical spine. And that would be also my preferred method if the awake traction reduction failed to reduce, and I would actually perform a posterior reduction and posterior fusion instrumentation at the same sitting. So in summary, this is a spine emergency. Awake traction reduction is the safest and fastest way to decompress the spinal cord, and it can be performed in center without spine surgery service. And emergency reduction is only necessary if we cannot achieve awake reduction. I thank you for your kind attention.
Thank you, Professor C.C. Wong. So next on the program, we have welcome Dr. Gabriel Liu from Singapore, who's going to talk about central cord syndrome, surgery versus conservative. Please, Professor Liu.
Thank you, Kenny. Thank you very much. And then if you can, yeah. So once again, I want to thank APSS for the kind invitations and also invited SSS, Singapore Spine Society, to join this prestigious event from APSS. The topic is given to me is to talk about central cord syndrome, surgery versus no surgery. Well, the management of this is really quite controversial to a certain extent, but having said that, it is a very common problem. As you know, spinal cord injury occurs in cervical spine. More than 55% and half of all this injury in the cervical spine. The reason for injury or significant injury is due to two mechanisms. One is the acute direct trauma, which occurs in the first stage. Subsequently, the ongoing edema and also chemical process damaging of the nerve inside, which occurs the next 3 to 6 days and plateau over the 9 days. All of us will assess the spinal cord injury using ASIA score, and which is classified based on ASIA A all the way to ASIA E. ASIA A being is a complete spinal cord injury where you cannot move and cannot feel anything, or incomplete spinal cord injury where it's ASIA B all the way to ASIA D. In incomplete spinal cord injury, of course, we know we have central cord syndrome, anterior cord syndrome, posterior cord syndrome, and Brown-Sequard syndrome. And we will be focusing on central cord syndrome, which is described by Schneider in 1954, which in short is that your arms cannot move, but your legs can move. But if you want to further define them, which is the motor score difference in the upper limb more than 10 points, this is also associated with bladder dysfunction, usually retention, and it is the most common type of incomplete spinal cord injury that you get in the cervical spine. As Dr. C.C. Wong already talked about the Staxis study, I think in the last 10 years, there's a change towards from conservative treatment of cervical cord injury to surgical treatment. This is based on the fact that of the Staxis study, as mentioned early on. And basically, in short, is that if you do the surgery more than 24 hours before 24 hours, the reach for the injury, at 6 months, you will have 2 grades of ASIA score improvement of the cervical cord injury. So with that, in the AO Spine platform, Michael Failings in 2017 in the Global Spine have come up with a consensus together with a literature review and suggested that for early surgery should be recommended to all cord injury for at whatever level. For example, in the cervical spine, you will expect 2 ASIA grade improvement. Thoracolumbar spine, you also increase 2 ASIA grade improvement, whereas even the others, you may be improved, particularly in ASIA B, C, and D. They also move on to recommended for traumatic central cord syndrome without mechanical instability. These patients should also offer surgery within 24 hours. The concept and the philosophy is that they viewed that even a small neurological improvement can be clinical meaningful. So the question is there anything changed since after that? Does doing more surgery, early surgery, leading to more complications? Well, some will look into from the acute traumas group and the registry database, basically look over 1,000 patients and identify if you do early surgery, and then they might be increased mortality in acute central cord syndrome. And each day delay, you might reduce a 19% mortality. But in terms of other side effects, they may not be statistically significant. This might be similar to the Taiwan registry as well. They talk about if you have a spinal cord injury, the chances for you to get a heart attack is higher than people with no spinal cord injury. So the risk factor, including, as you would know, the cardiovascular instability problems such as ischemic heart disease or renal disease. But interestingly, people with thoracic cord trauma, they are at risk of getting more heart attack than the others. But subsequently, in 2019, in a larger study, 2,300 patients, basically from the American database, and they've actually concluded that there is no significant increase of mortality rate between early surgery versus late surgery. And most of these risk factor tends to be confounding with one another. When you match them using a propensity match sample, there's no difference. But having said that, the trend may increase mortality, for example, such as increased age, increased Charlson comorbidity score, higher severity score, or the patient has initial GCF less than 15. How about surgery based on the ASIA grade? Well, traditionally in 2008, when the ASIA score comes out, the people with ASIA A, the chances for them to walk again is very minimal. Therefore, and patient with ASIA D, chances for them to walk again is 95%. And subsequently, after that, then, is there anything changes? In a recent date meta-analysis in 2019, because of the early surgery in Asia A patient, they have demonstrated that in Asia A patient, if you do early surgery less than 24 hours, there is a significant higher chances for them to actually improve in terms of neurological grade compared to non-surgical treatment. So there is a trend towards even Asia A patient that we should consider surgery for them. And how about the difference in terms of the various different Asia grade? Well, in this particular study, basically they talk about the support surgery for any of the spinal cord injury, but particularly in central cord syndrome that is associated with fracture and instability, surgery will lead to a faster recovery. An Asia C patient may be a good candidate for surgery and have an earlier recovery, whereas Asia D patient, you might be able to observe for a little while and then and consider surgery subsequently. So with all these things, there might be some new consensus. And then in a recent Spinal Cord Society Spinal Trauma Study Group positional statement, again, they really still cannot confirm whether conservative treatment versus surgical treatment. I see many of the speaker in the panel is actually in this study. And then the early surgery seems to be better. And in general, if you have a cord injury with fracture, you should do surgery. And therefore, these are some of the consensus. And in this year, from Lancet Neurology, the consent statement is still less than 24 hours. You do surgery, try to do surgery within 24 hours, that would have a better neurological outcome. If you delay more than 36 hours, then your opportunity might have lost. This is a little paper that intrigued me a little bit, talks about the size of the compression of the cord, may also have a clinical significant input. So they suggest if the cord injury, more than 60% cord compression and Asia A, even though you do surgery within 4 hours, then the chances of recovery is not high. So in summary, management of the acute traumatic central cord syndrome is still controversial. Now, trial of conservative treatment may be Asia D with no fracture, medically unfit, especially when they have cardiovascular insufficiency, or maybe patients who are already Asia A, more than 60% cord compression, already have more than 72 hours and there is no instability. Then in this situation, you might plan to observe in this situation. Whereas people will always agree for surgery if there's a central cord with fracture or instability. Asia C patient have a better prognosis, younger patient have better prognosis, and cord compression with less than 50%. Then if you are going to do the surgery, the consensus is do it less than 24 hours, and there's no increase of complication. High dose steroid is not indicated unless it's due to tumor. And in general, my feeling is similar to the AO Spine's feeling that small little neurological improvement may be clinical meaningful. Thank you very much for your time. We're looking forward to invite you all to come to the Singapore annual meeting together with PASMIS next year in 30th and 31st of July in Singapore. I'm sure my next speaker will talk about it more. Thank you.
Thank you, Professor Liu. So we're now entering this time for discussion for a few minutes or so. So if any of you listening to the webinar now, please post your questions to us and we will ask the speakers for you. But perhaps to start off with, maybe I'll ask Professor Liu. So, in addition to surgery, is there anything else we can give to these patients to improve their chances of recovery? Because, we are already doing decompression quite well and most surgeons are doing as best as they could. So is there anything on the horizon that you know of that we should be aware looking after?
Yeah, I mean, looking at this, thank you very much for the questions. I mean, looking at this, it's actually difficult to tell. The early surgery seems to be one of the major improving factors. As you know, they have already talked about using hypothermia maybe is a possibility, but global whole body hypothermia, I think, is still a problem. Localized hypothermia in the neck is under development at the moment, but there's no product is available at this point of time. Using sodium channel blocker, rhizonium, whatever that Riluzole. And then again, microfailing sting is useful, but I think our president, Professor Rajasekharan's study demonstrated there's no effect. From Japan, the using of the GCSF have seemed to be a good prognostically improve of the function. We're waiting for the phase 3 trial outcome data to show. Thank you.
Thank you.
Yeah, I think is there a question from Professor Chhabra? Maybe you can ask it online.
Sorry.
Will you want to ask it online, or you want me to read out the question?
Yeah, can you hear me now?
Yes, sure.
Yeah, now when it comes to vertebral fracture, dislocation, or traumatic disc herniation or instability, there is better outcome with early surgery. There is evidence as also revealed by our meta-analysis. However, in patients of acute traumatic cervical spine, central cord syndrome, secondary to extension injury in a stenotic cervical canal, without a fracture or a dislocation or a traumatic disc herniation or an instability, there is no clear consensus on whether we should go in for early surgery, or we could have a supervised neglect and go in for a surgery if the recovery plateaus or if there is neurological deterioration. So would you agree to that? Do you have any comments on that? I think there is a need for more evidence on what works better in such cases. In general, in a stenotic canal with a hyperextension injury, there is no clear-cut evidence on what works better.
Yeah, Professor Gabriel, would you want to answer the question?
Yeah, thank you very much. And then I noted I think you are one of the co-author that I've quoted. Anyway, right. So but I understand that your society, there's the general statement over that area. But my personal opinion is thinking, okay, if there's something pressing on the spinal cord, we know something pressing on the spinal cord will create damage. We know in cervical myelopathy, and morphological MRI and study demonstrate even a little bit pressing on the spinal cord, the cord will continue to deteriorate over the years. So to a certain extent, yes, if there's something pressing on the cord, maybe relief of the compression of the cord is important. And that especially in the acute traumatic situation, that the injury is, the mechanism of injury is not only the acute trauma, but the secondary injury to the cord, which is the edema, the ongoing deterioration the next 9 days or so is important as well. So I'm of the opinion, even if there is obvious compression, if the patient is medically stable, go for early surgery. Thank you.
Thank you.
Yeah, I have a question.
CC, what do you think, CC?
Oh, okay.
Do you have anything to add? Professor Wong, CC?
I would concur with Chhabra that this is still controversial. I think there are, if you look across the board, there are people who are tend to be more aggressive, that they decompress and perform early surgery or even fusion. And then the other hand, there are people who treat this conservatively, and some in the middle where you treat them conservatively only when the neurology status continue to deteriorate, then they perform decompression surgery. So I don't have anything to add, but just to say that it is a lot of different variation in practice as far as this condition is concerned.
Yeah, I think Prof. Arif wants to give a comment or ask a question.
Yes, I have a question from CC. CC, first of all, thank you very much for a very nice presentation on flexor dislocations.
Thank you.
As you know, many of these patients present to us late and sometimes too late. And sometimes they even come after like 2 months or 3 months after the injury, especially if the neurologically they are intact. So how does your management change? Is it different from the acute dislocation management, or is there any difference in the management if they present to you late?
Thank you for this question. Actually, there's also one of the reasons why I think we should teach our colleagues who are in non-spine hospital or non-spine surgeon hospital to be able to perform this awake cervical reduction technique. Then you don't have this neglected situation. But anyhow, we still do see them. Either they have other concomitant injury, then this injury got missed, or sometimes patients just don't get access to the facilities enough. So in that situation, obviously, we cannot perform a close reduction because if it's a several months down the way, there will be a lot of fibrosis or even contracture. In that situation, normally we will have to perform almost always both anterior and posterior surgery. So I will perform my anterior discectomy, basically a release procedure from the front. And then I turn the patient to the back, and that's where I reduce the dislocation. Basically, still sometimes even have to excise some of the articular facet to facilitate reduction of this jump facet bilaterally. And sometimes I just stabilize and fuse on the back. And sometimes I turn back to the front again to insert a piece of bone graft in the empty disc space, which I performed the discectomy earlier. So it's kind of a lot of work, but I think that will be, for me, the safest way to get the reduction without injuring both the nerve root and also the spinal cord.
Thank you. And is there any cutoff time limit when you would like not to apply traction and straight away go for anterior decompression and then posterior?
If the patient actually comes to my hospital and we have the operating theater facilities available to him, then I would think that we can actually perform that. But that is not very common. So that's why I still think that if we can actually reduce the dislocation using a closed method, then you will actually already decompress the spinal cord, and you will be able to just list the patient for fusion procedure, anterior or posterior, up to your choice, on a semi-elective or semi-emergency basis.
So even if they come like 3 months later, you will still apply traction and see?
Oh, no, sorry. 3 months, of course not. Yeah, I'm saying those acute injury. 3 months will be what I told you, that we will actually perform anterior posterior surgery. It's release and reduction.
Okay, right. Thank you.
Yeah, thank you.
Yeah, I have one question for Prof. Wong, and maybe Prof. Gabriel can contribute and others can contribute to this. Do you routinely do MRI prior to awake reduction of the dislocation?
No, from my presentation, you have seen that actually I'm quite confident that the traction actually sucks in the disc, and that even if there's an existing small disc prolapse, I'm not worried that the reduction will cause us increase in the size of the prolapse.
How about Prof. Gabriel? Would you want to comment?
I think, I would agree with CC, and then in general, the consensus from CSRS, and then basically demonstrated that awake reductions prior to MRI is indicated, providing two things. One, the patient is not a change of sensorium, and then there's no distracting injury to a certain extent. But in Singapore setting, and then we are quite lucky, and then we get OT and MRI reasonably quickly. And so in my practice, and I'm sure Jacob and Dinesh will talk about it as well, that I would tend to do an MRI quickly, and then before I actually do anything else. And I tend to do traction just before I start surgery to reduce it in OT, and then go for the surgery.
Yeah, thank you, Prof.
On the scalp tongue, Gabriel?
Yes, on the scalp tongue.
Okay. Yes. Actually, sometimes even just putting the patient under anesthesia will already reduce it, right?
Yeah, or just pull
yeah,
under
yeah.
II. Yeah.
It's so unstable, right? Okay.
Yeah.
I think the difficult
Especially
one
the-
is a unilateral.
Yeah. I mean, the facet dislocation with a fracture is the one that we worried about, because the minute we pull a little bit, the whole thing will dislocate rather than yeah.
Thank you.
Okay, thank you. Another question to the panelists and other faculty is that very often patient will exhibit ACA neurology when the patient is in spinal shock. Since surgery is indicated less than 24 hours and spinal shock may not be over in that time period, how do you know whether the patient actually has ACA or has a better neurology? So how do you differentiate it before going in for surgery? Is there any comment? Maybe Prof. Gabriel, maybe you want to comment?
Sure. I think most of the study on this type of study, you are absolutely nail on the coffin. And then this that we don't know whether they're in spinal shock, they're not in spinal shock. Again, in our practice is that whether if the patient is fit for surgery to a certain extent, if there's severe dense neurological deficit, and then if there's a obvious problems, and then we might tend to go for surgery. So for example, one of the reasons why I didn't record this talk and send it to you is because yesterday I have an OPLL with 60% cord compression with huge OPLL, and the guy cannot move the arms and leg. I'm not going to wait for another 3 days later before I would do anything to it. So that's why straight away we have been arranging the surgery, and then straight away that day we have done the surgery for the patient. That is our current practice. Thank you.
Yeah, I think there is a very valid point that the documentation of the neurological status may be difficult. But I think if you look at those studies that advocate surgery within 24 hours, I would think that it's quite obvious that is the decompression that makes a difference, because that same phenomenon occurs in both the early surgery group or the late group. Right. And in that sense, I would still think that if we are going to try our best to help the patient, I think we should also try to offer decompression early.
Thanks, Prof. Gabriel and Prof. Wong. Maybe someone from the panelists, would you want to comment?
Hi, Dinesh here from Singapore. I just want to add that for spinal shock can sometimes last for weeks or even up to 6 weeks or so. So I think it's not feasible to wait for spinal shock to end completely before we make a decision whether to go in or not. And if we can safely perform the surgery within 24 hours, I think that is still the ideal standard we should aspire to. Thanks.
Thank you, Prof. Dinesh. Prof. Chhabra, you have a comment?
Yeah. I think this point is used as a critique by proponents of delayed decompression against early decompression. They say that the results of the Staskis study were confounded because many of the patients would have improved neurologically even otherwise, because they were actually not AISA, and it's actually the neurology at 48 hours, which is actually considered to be more predictive of the long-term prognosis of the patient. However, if you compare the outcomes between early and delayed surgery, as was mentioned earlier, the scenario would remain the same. So you can compare the results, and if there are better results between the two. It is difficult to have a good level of evidence, a randomized controlled trial, when you feel that people will improve with early surgery. The ethical issues do come in. So it may not be of consequence per se.
Professor Chhabra, are you aware of any prospective studies, or what do you think is the need, or where do you think is the gap in knowledge that a prospective study can help in these situations? Since you've done a lot of work on the review of the literature.
See, I can only say, I have heard both, our spine trauma study group is also Dr. Michael Fallings and also Mr. W.L. Masri, right? So proponents of conservative treatment and proponents of surgical management. So what the proponents of conservative management say is that in the early stage after spinal injury, there is a stage of physiological instability. And if you tend to operate, if you do not, for example, maintain a mean arterial pressure of 85 mm during surgery, then the outcomes, long-term outcomes get compromised. And they also say that if you mobilize the patient early, then the physiological instability may reduce the mean arterial pressure during mobilization and compromise results. So the idea of early surgery is confounded. Whereas if there is any canal compromise, they say there is remodeling of the canal, and with time it doesn't have an effect. However, the proponents of early surgical management advocate that now most of such studies which mentioned this were studies conducted long before, when hemodynamic instability could not be controlled well during surgery by anesthetists. But with advanced techniques, it can be very well controlled, as was also brought out by Staskis study. Now, we all agree that it's difficult to conduct a study. There is a need of good study, definitely, but some people believe and some don't believe. So ethical issues do come in. And if you have a multicentric trial, the level of evidence would not be good because there would be inter-observer variability. So that's why, but more and more people are in favor of early surgical management, and there are very few now who believe that it should be delayed or we should go in for conservative management per se.
Thank you very much, Prof. Chabra, for your detailed explanation. So I think we have to move on to the next session. Thank you very much for the speakers in this session and the other faculty members for contributing to the discussion. All right, the next session will be given by Professor Arif on modern classification system on thoracolumbar spine trauma.
Hello everyone, my name is Professor Arif Khan, and today we will be discussing the modern classification systems of thoracolumbar spine trauma. I have no disclosures. Classification of thoracolumbar spine trauma has evolved over the last 80 years, and there are several classification systems currently available, and this is because there has been no agreement on the goals of classification, on the anatomical structures to consider, and on the definitions of various parameters. Some classifications are based to direct toward the treatment, others are just to help in communication. All the previous classifications or the older classifications were based on findings of the X-rays, while the most current classification use the CT scan findings. So mostly these classifications are based either on the mechanism of injury or on the morphology of the fracture. The Cole was the first one to classify these injuries into stable and unstable injuries. These were based on the probability of increasing deformity and spinal cord injury. Now, Holdsworth modified and expanded this classification and developed or proposed his two-column theory, which became the foundation for all the current or the modern classification systems of thoracolumbar spine trauma. And according to this classification, there were 5 groups, these including pure flexion injuries, flexion and rotation injuries, the extension injuries, vertebral compression, fractures, and shearing injuries. Dennis in 1983 proposed the third column, called it the middle column, which per se was not an anatomical column, but this was used to determine the injury type and risk of the neurological injury. And based on this classification, there were 4 different groups of injuries: compression injuries, burst fracture, seatbelt injuries or the chast fractures, and fracture dislocations. Now, Margul in 1994 and their group, they developed a very extensive classification system, which they called as the comprehensive classification system. And according to this was based according to the style of the AO, a 3, 3, and 3 types, each one having further 3 types, and each further type has further 3 types. We are not going into the detail of those subtypes, but there were main 3 groups. Type A were compression injuries and having 3 subgroups: impaction fractures, split fractures, and burst fractures. Type 3 were distraction injuries and having primarily ligamentous and osteoligamentous and entire destruction. And type C were any injury, compression or distraction associated with displacement or rotation. And the severity of the injury could be estimated by going along the different groups of the classification. So if we move from one group to the next, to the next, and to the next, and along the subgroups, the severity of injury would increase. Now, Pokharel, in an attempt to develop a classification which can be more objective and which could guide towards the treatment modalities as well, they developed a classification system which they called a thoracolumbar classification, thoracolumbar injury classification and severity score, or the TLIC system. And this was based on 3 parameters: the morphology, the integrity of the posterior ligamentous complex, and on the neurology. And based on morphology, there were 4 types: the compression, the burst, the rotation, and the distraction injuries. The posterior ligamentous complex could be intact or indeterminate or intermediate or disrupted. And the neurology could be intact, or the nerve root injury or cord injury, which can be complete or incomplete, or cardiac vein injury. Now, all these types have its own points, and the total score is calculated by adding these points. And if the total score is less than 3 points, the treatment usually would be non-operative. If it is more than 5 points, the treatment is operative. And if it is 4 points, then it could go in either direction. And there were 2 type of modifiers also added, which could help in decision making. And these were the local factors like extreme kyphosis or multiple rift fractures or open fractures, and the systemic factors like diseases including rheumatoid arthritis or ankylosing spondylitis that could influence the decision making process. Now, there were certain limitations to this TLIC system, and these including that although this could guide us toward the operative or non-operative treatment, it could not guide us toward the approach, whether anterior approach should be followed or posterior approach should be followed in a particular patient. Similarly, the posterior ligamentous complex for the first time was given its due importance. However, it was not shown or not made clear to the clinician on how to diagnose a PLC injury. Similarly, modifiers were added, but it was not clarified to the clinicians on how to use these modifiers. AO in 2013 proposed its own classification system, which is currently the most commonly used classification. And this was basically a more systemic and revision of the Mogul classification system, and they incorporated both the morphology as well as the clinical factors which were relevant for clinical decision-making process. And these were based on 3 parameters: the morphology, the neurology, and the clinical modifiers. Type A were compression fractures, type B were distraction injuries with the tension band mechanism is lost, and type C were any compression or distraction injuries associated with dislocation or displacement. Type A were further divided into 5 subtypes, which included non-structural fractures or wedge compression or split fracture, incomplete burst or complete burst. And type B injuries were B1, which was the monosegmental pure osseous failure, B2, osteoligamentous failure of posterior tension band mechanism, and B3 were the anterior tension band mechanism failure. And type C are any of these fractures associated with displacement or dislocation. They are the most severe injuries and associated with high incidence of neurology. AO has proposed an algorithm for classifying fractures according to this system. And to begin with, look at the displacement or dislocation. If it is there, this is type C injury. If it is not there, look at the tension band mechanism. If the anterior tension band mechanism is lost, this is B3. If the posterior is lost, this is either B1 or B2. If the tension band mechanism also is intact, look at the vertebral body. If there is a fracture, if the vertebral posterior wall is fractured, this is either A3 or A4, which is a burst fracture. If that is intact, look at the end plates. If they are fractured, these are either A1 or A2. And if they are also intact, there might be a non-structural injury, which is A0. Now, neurologically, these could be classified into an intact neurology or transient neurological deficit, which no longer present radiculous symptoms, incomplete spinal cord injury, complete cord injury, or neurological injury, which is indeterminate. Now, there were two clinical modifiers added to this classification. One was when the PLC injury is indeterminate, and second, where there were certain systemic problems like ankylosing spondylitis or burns that could affect the decision-making process. So just to summarize, the most modern classification systems are based on the morphology or mechanism of injury or the integrity of the PLC and the neurology. Modern classification uses findings of CT scan instead of plain X-rays, and a good classification should not only help in communication in different countries and culture, but should also guide towards developing management strategies and predicting prognosis. Thank you. If there are any questions, I'm here to answer.
Thank you, Prof. Arif. So we will have a Q&A session at the end. So we will move on to the next talk by Dr. Pankaj Kandwal on thoracolumbar burst fractures, management strategies. Thank you.
Warm greetings from AIMS Rishikesh, India. I'll be talking on management strategies in thoracolumbar burst fractures. I'll be talking about evaluation workup, non-operative versus operative, surgical approach, and the controversies associated with it. Evaluation of a patient starts in the ED, where you look at the airway, breathing, and hemodynamic status. Once you've ensured it, you do a comprehensive neurological examination, which is followed by radiographs, CT scan, MRI, and then you tend to classify the fracture. TLX is one of the widely used classification system, which factors in the morphology, integrity of posterior ligamentous complex, and the neurological status. A TLX less than or equal to 3 is conservative treatment, 4 is a gray zone, more than or equal to 5 means operative indication. There's been a lot of stress on the integrity of PLC, and on X-ray you can look at if there is a vertebral body translation, if there is interspinous spacing more than 7 mm, more than 50% of compression of height, more than 30 degrees of segmental kyphosis, or if there is fracture of the spinous process. These are indirect indicators of PLC injury on an X-rays. However, MRI is the most useful investigation to check the status of PLC. A 40-year-old male laborer fall from height, known deficits, and you look at the X-rays, there is a fracture of L1, looks like a burst fracture. You are tempted to manage this patient conservatively. On an MRI, if you get MRI done, this is a stir sagittal image where you see how the PLC is appearing bright, and thus the management would change. Coming on to non-operative management, in neurologically intact patients, this meta-analysis showed that the functional outcomes is going to be very similar whether you manage them with surgery or you manage them conservatively. Now coming to complications in non-operative versus operative, this meta-analysis showed that there was no significant difference in overall adverse events. However, there is a trend towards complications which are unique to surgical group, like implant-related and infection. The TLX, apart from guiding you whether to operate or not, will fairly tell you if the patient can be approached from behind or you have to go for anterior. Looking at this table, most of the fractures with the disrupted PLC is managed from behind using the posterior approach. Now, if the patient has got intact PLC or he has got incomplete spinal cord injury, maybe in a candidate for anterior approach. Posterior approach, we all are well versed with, is recommended in most of the cases where there's PLC disruption. It allows good restoration of lordosis. You do good decompression of the neural elements. Just remember the loss of kyphosis, which may be expected over a period of time. McCormack Scoring will guide you if you have to do anterior column reconstruction when you're doing a short posterior fixation in burst fractures. You can supplement the short segment with the index screw. You can reconstruct anterior column with the help of a cage, all from behind, or you can do a long segment fixation. All three are possible if you are managing from behind. McCormack load sharing classification of lately has come under scrutiny, and this meta-analysis shows that a score less than 6, the scoring or the classification system may be reliable, not otherwise. Anterior approach, as I mentioned before, is rarely done, but it is reserved for patients who have incomplete deficits and where there is intact PLC. You get better decompression of the canal. Short-term correction is inferior to posterior approach. However, the loss of correction over long term is as good as posterior. This R series, which published recently in Journal of Orthopaedic Trauma, 36 patients, and we had very good neurological, radiological, and functional outcome in burst fractures. One such example where we did anterior decompression and instrumentation. Now, whether anterior is better or posterior is better, it's still controversial. This meta-analysis highlighted that anterior approach has longer duration and is associated with increased blood loss. Looking at the radiological, neurological, and functional outcome, it is similar to the posterior approach. We did a similar prospective study in year 2018 to 20, and if you look at this table, the duration of surgery and hospital stay is significantly more in anterior group, while blood loss, kyphosis correction, and loss of kyphosis correction is similar. Looking at the pain scores and the functional outcome, in the early post-op, the posterior approach has better pain scores, while in long term, the results are very similar. Quickly touching on to the controversies, one is timing of surgery, and there is enough high evidence literature existing which support early fixation. A fixation within 24 hours is associated with shorter hospital stays. It optimizes neurological and functional outcome, and patient will have decreased pain as well. The next point of contention is whether to decompress or not. This is one of the interesting study which I came across, where there was a long-term follow-up, and then they showed that there was a decrease in canal compromise at 3 to 4 weeks without decompression. All patients with incomplete deficits had a recovery of at least 1 grade, and they questioned the need for decompression in burst fractures. Next controversy is to fuse or not. This is one of the meta-analysis of 5 randomized and quasi-randomized trials, 220 patients, follow-up of almost like 70 months. They concluded that arthrodesis does not improve clinical outcome. It is in fact associated with increased surgical time and higher intraoperative bleeding. It does not promote significant improvement in radiological parameters. Minimal invasive surgery is one of the viable options in the management of burst fractures, and all the advantages of MIS may be passed on to patients with fractures with good evidence in the literature. All in all, to conclude, TLX less than 4, neurologically intact patients, conservative treatment. A score of 4, operative or non-operative, very similar results. Operative approach, in case you want to do it, basically depends on the surgeon's expertise and preference. Posterior approach is reserved for partial and complete deficits and where PLC is disrupted, while anterior approach is reserved for partial deficits and intact PLC. Thanks.
Thank you very much, Dr. Pankaj. We'll move on to the next lecture by Dr. H.S. Chhabra on short segment fixation, when, why, and how.
Hello, I thank Asia Pacific Spine Society for giving me the opportunity to present on short segment fixation, when, why, and how. This will be the overview of the presentation. Long segment fixation is when constructs are spanning 2 to 3 levels above and below the fractured vertebra. Short segment is when constructs span 1 level above and 1 level below the fractured vertebra, limiting the number of segments instrumented to the very minimum necessary to restore sagittal balance and stabilize the fracture. When we look at the biomechanics, long constructs applied in thoracic and thoracolumbar segments impart 3-point bending forces to maintain neutral thoracolumbar sagittal balance and moderate thoracic kyphosis. When we look at the biomechanics of short segment fixation, they provide stability depending on cantilever bending forces or anterior column integrity to maintain sagittal lordosis. The anterior column reconstruction reduces implant loads by delivering anterior axial loads directly to the intact vertebral column subjacent to the fracture. Screws resist extension, translation, and torsional forces. Why short segment fixation and why not long segment fixation? It was hypothesized that long segment posterior fixation may avoid the biomechanical and sagittal profile shortcomings associated with short segment fixation constructs. Thus, long segment fixations may obviate the need for any anterior column support. However, there are biomechanical studies which show no significant superiority of long segment fixation over short segment fixation. There are finite element analysis also which conclude in this regard. When it comes to the kyphotic angle, this meta-analysis showed that in 4 trials, there was no conclusive evidence that there was any difference in the final kyphotic angle between short segment and long segment fixation. In this meta-analysis also, short segment pedicle screw fixation was not significantly different to long segment pedicle screw fixation in terms of improvement of back pain and return to work, and also in correction of kyphotic deformity. Saving levels, as we know, is of paramount importance in lumbar and in thoracic spine. It preserves lumbar spine flexion and extension and thoracic spine rotations. And this becomes all the more important in people with neurological deficit because they're on the wheelchair and they rely on rotations in order to provide, make them more independent and rehabilitated. So this is of vital importance. As the fusion levels increase, the compromise on the mobility of the spine would increase. The number of levels become very important in the lumbar spine, as we are all aware of, and hence we have to take this into special consideration. There were reservations with bridging short segment instrumentation in that it provides inadequate reduction of fractured vertebra, insufficient correction of kyphosis, and it may lead to implant failure. If there was inclusion of the fractured level in short segment fixation of thoracolumbar fractures with an index screw, the incidence of failure reduced significantly as came out with this study, and there was no, the mean worsening in kyphosis was less. There is also level 2 evidence in this biomechanical study that inclusion of the interfragmentary screw improves the biomechanics of the construct, and we do not need a long segment construct in this regard. So in this meta-analysis also, the combined screw fixation technique was associated with better reduction of the fractured vertebra, less correction loss in the follow-up, and lower implant failure rate. Another meta-analysis which also supported that adding intermediate screws at the fracture level results in less post-operative pain and better radiological outcomes with less implant failure. If the anterior and middle spinal columns cannot share significant axial loads, the pedicle screw must bear those loads in a cantilever bending mode. The excessive bending moments generated at the screw hub result in a high rate of bending or fracture failure. Once initial bending failure occurs, further collapse is likely, causing progressive loss of lordosis associated with a higher incidence of clinical failure and pain in some patients. And augmenting the surgical construct with an anterior stud graft or cage restores the integrity of the anterior column, greatly reducing the cantilever bending forces on the screws. The anterior column reconstruction reduces implant loads by delivering anterior axial loads directly to the intact vertebral column and subjacent to the vertebra. We are aware about the load sharing classification. However, this systematic literature review showed that short segment posterior instrumentation only can be sufficient and safe enough in treating thoracolumbar fractures regarding of the load sharing classification. This meta-analysis proposed that there are other factors such as neurological status, integrity of ligament complex, trauma mechanisms, and time of injury, which should be better studied in association with the criteria defined by McCormick, and risk of implant breakage and loss of kyphosis correction in isolated posterior fixation is low, even with values more than 6. So the surgeon could assess on case-by-case basis with a load-sharing classification score of more than 7. One can still do short segment fixation and assess for implant stress and follow-up. For most cases, short segment fixation would suffice. And this study showed that adding cross-links to the short segment posterior fixation improves stiffness and decreases motion in axial rotation. Now, long segment fixation, however, would still be required in cases of osteoporosis, as was shown by this study. And long segment fixation was also shown in this study to have better kyphotic angle correction and less failure, implant failure. Similarly, in ankylosing spondylitis, long segment fixation may be advisable. Now, coming to a few case studies, this was a traumatic L4 burst fracture with Asia D, and also with an L1 fracture, but we fixed only L4 with an anterior augmentation with good results. You can see the interfragmentary screw at the fractured level. So this was another traumatic L3 fracture with a fracture at the index vertebra, and an L2 burst fracture. You can see with good results. We have used an anterior augmentation with a peak cage at the disc. And this was an outside elsewhere operated case which was revised, and where we have used an index vertebra and also an anterior peak cage for augmentation. So short segment fixation is as good as long segment vis-a-vis stability with added advantage of saving levels. The construct should be supplemented with intermediate screws whenever possible. Anterior column support is advised in cases with short segment fixation if injury is 3 column, and long segment construct is indicated in patients with modifiers like osteoporosis and ankylosing disorders. So thank you for your patience, and I'll be happy to answer any questions. Thank you.
Thank you, Professor Chhabra. This very, very nice, comprehensive talk. Maybe I will start off with asking you a question. Do you sometimes, or in any situation, offer fixation without fusion, and then maybe after the fracture heals, remove the implant? Is there any situation where this is a suitable strategy?
Yeah, that may be a suitable strategy, but in the Indian circumstances, most of the patients would want to shirk away from a second surgery. And even if we give them the option, they would say, okay, you do whatever you can in one go. Of course, that may have been more suitable when we had used long segment fixation. But now where we mainly go in for short segment fixation. Also highlighting that in patients with neurological deficit, it is very important to have short segment fixation because these patients are on the wheelchair and rely on rotation at the thoracic facet levels to be more independent on the wheelchair. But if you fix long, then this gets compromised and their overall rehabilitation gets compromised. So ever since we've been using short segment fixation, we have not felt the need to offer this. And a fusion generally would take place by itself unless it is a purely discoligamentous injury, which is very rarely the cause. Wherever there's a fracture, fusion generally does happen. You don't need to add a lot of other graft, but just prepare the surface for bone fusion to happen.
Thank you.
Maybe the other speakers can comment on this. Do you do stabilization without fusion and remove the implant later? Maybe Prof. Arif?
Yes, I would agree to Chhabra. You see, it's like in general orthopedics, once we fix a fracture and the fracture heals, it just goes on whether the implants are there or they are not there. It doesn't make any difference. So similarly, once we stabilize with a short segment fixation and the fracture heals, it just takes most of the weight, although still some weight passes through the implant, but the fracture itself can bear most of the weight, and we don't need to do any additional fusion with it. Maybe in few cases where there is a pure ligamentous injury and the posterior column is unstable because of ligaments and there's no fracture, we might need to do fusion. But those circumstances, in my personal view, are very rare, and we are okay with non-fusion and short segment fixation in most of these cases.
Yeah, do you routinely remove the implant after fusion or union occur?
No, not in short segment. And again, our circumstances are the same in all the developing. The patient, unless they have some problem with the implant, they would usually not like to have another surgery.
Maybe Dr. Pankaj, I see that you have you have used MIS as one of the technique. Maybe you want to comment whether you use a non-fusion technique and removal implant later.
Well, I would reserve this situation for patients who are young and who don't have a deficit. I may give them an option of removing implant later. But yes, I agree that most of the patients don't want to get a second surgery. But that's a very small group of patients who don't have a deficit, and young patients and burst fractures with PLC injury. Maybe once the fracture is healed, there could be a chance, there could be an indication for removing the implant.
Okay, maybe to add to this, I just give another scenario. What if there is a burst fracture of L4 and you have fused from L3 to L5? So would you remove, because those are the segments where the motion of the lumbar is more than thoracolumbar region? I
think once you have fused the vertebra, retaining the implant or removing the implant, this question doesn't come, Chee. I think you can very well retain the implant in case you're fusing it.
I mean, would you do non-fusion technique and remove the implant later, like what Kenny has suggested?
Yes, again, as I said, a burst fracture, maybe a A3 kind of fracture where the fracture is healed, where I haven't fused it. Maybe I can give that option to the patient.
Any comments from Professor Chhabra or Dr. Professor Arif? If the fracture is at L3 or L4, which the spine has more motion, so
you have a point there in that L3 lumbar burst fractures are a different ball game than thoracolumbar burst fractures, because there is the peak of the lordosis and you do not have a kyphosing effect on the fracture. And but most of these fractures may heal with the conservative management also, unless there is a substantial neurological deficit. If there is a substantial neurological deficit and if you have to operate, normally one would augment anteriorly to have a short segment fixation. So if you augment anteriorly, normally it would require a cage to transition from, say, L3 to L5. So in this situation, removing the implant, as Pankaj said, may not be useful, unless you have a situation where you may just need to do disc fusion between L3, L4, or save one level, then you may individualize and consider removing the implant subsequently. But I have rarely faced those situations. So most of these cases, you do a short segment fixation, but you would not gain in removing the implant subsequently. I would also want to use the opportunity to mention that with regard to fusion, there is evidence published in literature, including that from Dr. Rajashekharan, that you don't need to fuse. It fuses by itself unless it is a purely discoligamentous injury. Thank you.
Actually, Professor Chhabra, can you help us to outline maybe to our audience, when in the absence of neurological deficit, when do you choose to conservative management, non-operative management? Maybe you can explain to our audience.
So, see, thoracolumbar burst fractures are a different ball game than the fractures with other morphology. And in thoracolumbar burst fractures, the concept of stability is different, and most of them, there are studies available, evidence available, especially from Korea, that most of them can be managed conservatively, even if you think that the posterior ligamentous complex is affected. So you can give a good conservative trial in these patients. In other cases, we would consider the injury morphology, whether it is stable or unstable, the injury stability, and neurological deficit. So if there is no neurological deficit, there is a good chance of the injury being stable. But in such situations, you may consider a surgery only if the fracture is likely to heal with a kyphotic angle, which is unacceptable. So if it is a chance fracture, whereby you have through the discoligamentous injuries which don't heal by itself, in other cases, if there is no neurological deficit and if it is not likely to heal with a substantial kyphotic angle, you could manage these patients conservatively as well. In fact, we just concluded with the joint North American Spine Society and ISCOS workshop in the recent NAS and ISCOS meetings. And I was asked to talk on conservative management in patients with neurological deficit, in spine trauma with neurological deficit. So even there is a scope to manage conservatively, but there are clearly defined indications also with them. This will be a long topic to discuss.
Sure, yeah. No problem.
But conservative management in our protocols do find clearly a role. And I would want to bring to your attention also a recent publication in Spinal Cord this year itself, where we have published a simplified classification system for management of thoracolumbar fractures, where our friends could get an answer to everything that you've asked. So I would be happy to answer any questions subsequently if there are any.
Great, thank you. Professor Arif, did you have something to add?
Yes, I was just in continuation to that L4 fracture scenario. So in case of burst fractures of the L4, when both end plates are also fractured, the usual injury to the disc above and the disc below, and if we just stabilize it and remove the implants later, this patient would still be coming with back pain. And maybe sometime we will have to add fusion to it. So if we have just stabilized it and fused or not fused, if it's not fused and we remove, we might need to add fusion later on. And if we have fused, then there's no point in removing the implant and giving another surgery. So we would just like to keep it as such.
Yeah, thank you for the comment. So I have a question, maybe a scenario. If just say there is a patient with fracture, thoracolumbar fracture with retropulse fragment causing neurological deficit. So when will you, or would you not consider indirect reduction using ligamento-taxis method? And how would you determine whether the reduction is adequate or inadequate? Yeah, maybe start with Professor Arif, maybe you want to comment?
Okay, so to see whether the fragment has retropulsed or not, I think it matters on the neurological status. So if there is neurological injury associated with need to do the decompression. Now the question is, we need to do ligamentotaxis or not? So personally, I don't like ligamentotaxis much. I use the contour rod to help in the fracture reduction instead of distracting it, because that might actually aid to the injury to the spinal cord. And since with mostly doing posterior surgeries, we can do almost everything with the posterior surgery now. So if there is a fracture protruding into the canal, we can actually reduce it. We can put bone graft into it, and we can even do corpectomy and do a cage using the posterior approach. So that actually depends on the individual case. So if you think there is a fracture fragment, instead of doing a ligamentotaxis, I would like to reduce and remove that fracture fragments and protect the spinal cord instead of distracting it and adding more injury to the spinal cord.
Yeah, thank you. Maybe Dr. Pankaj, do you have any comment on this? Yeah.
So I understand that you're talking about a patient who has got deficit and a retropulse fragment.
Yes, correct. Okay. Both deficit and retropulse fragment. Would you still do an indirect reduction?
I would seldom go for indirect decompression. I'll go for a direct decompression in these patients invariably. Though, as I was quoting one of the studies where they said that decompression may not help even in incomplete injuries, they do tend to improve, and the canal very well remodels and other things. But in my practice, I tend to decompress them directly in presence of neurological deficit. Yeah.
Yeah, thank you. Professor Chhabra, do you have any comments on this?
Yeah, I think in acute fractures, most of the ligamentotaxis and correction takes place as you position the patient, right? So as you position the patient, normally it will fall back into position. I would not want to put too much stress on the implant by distracting, because then all the stress comes on the implant, right? And unless you are augmenting anteriorly, right? So if you are augmenting anteriorly, you may want to do indirect decompression, but normally if it is an incomplete injury, you may want to do a direct decompression, as was talked about, because the world is moving towards better results with a direct decompression in incomplete injuries, at least. In fact, people are also talking about decompression in complete injuries, because if you go in early, you are not very sure whether it's a complete injury or not, and you want to give the best chance to the patient. But there is a debate on this, because many people believe that remodeling does happen and you do not need to decompress, but we'll not talk about that. So in a nutshell, I would want to rely, unless I'm doing an anterior augmentation, I would rely on a direct decompression rather than an indirect decompression, if it is required after positioning the patient where much of the decompression does happen by itself.
Okay, well, thank you. We have had a very lively discussion. So I think what we'll do now is we'll move on to our very special guest nation session this afternoon, which is going to be hosted by the Singapore Spine Society. And I would like to hand over to Professor Gabriel Liu. Thank you for organizing this session for us.
Thank you very much, Chairman. And hello. Thank you very much, Chairman. And first of all, we would like to I just want to check. You can hear me?
Yes, we can hear you very well.
Okay, thank you. Thank you very much, Chairman. And then Once again, on behalf of Singapore Spine Society, we would like to thank APSS for the kind invite, and we look forward to working with APSS more closely and continue to contribute in the Asia Pacific region. So looking at the program this year, we're looking at the program that you have, we're talking about trauma. We thought it would be great to talk about two different aspects of the trauma, one particularly in MIS fixation, and also the other proportion would be osteoporotic spine fracture, which is a particularly important aspect of it. So with that, we have asked two of our prominent speakers from Singapore Spine Society. The first one is Dr. Dinesh Kumar, and then who is currently the head and the spinal director of service from Chung General Hospital, and he will be talking to us the first talk, which is the pearls for MIS fixation, MIS fracture fixation. So without further delay, Dinesh, thank you.
Hi, I'm Dr. Dinesh from Singapore, and I'm going to talk to you about MIS fixation for thoracolumbar spinal fractures. So I'm going to touch a little bit about the advantages of MIS surgery in the setting of trauma. How do we select a suitable case? What are some of the considerations that go into selecting the case? Some reduction and decompression techniques, as well as the use of navigation for MIS pedicle screw placement. Potential advantages are many. There is definitely less blood loss, less tissue trauma, decreased risk of infection, potentially faster surgery, faster post-op recovery with less pain. And because of all these factors above, it's particularly useful in polytrauma settings. MIS surgery, which is considered sexy surgery, often sells itself. There are, however, some limitations. The reduction maneuvers might be difficult. You may need to stage the procedure if anterior reconstruction is required. Decompression can be challenging through the tubular system. Fusion also can be difficult. And in terms of implant costs, it is, at least in Singapore, 3 times as costly. So which cases are suitable? I put up 2 CT scans here, and later we will look at what was done for them. All right. So in my opinion, the type A fractures, particularly the A3 and most commonly the A4 fractures, are very amenable to MIS pedicular fixation. Some of the type B fractures as well. For type C, where there is displacement and dislocation, I would personally prefer an open approach. So this is a typical MRI showing a common indication for MIS fixation of a L1 chance fracture. You can see the stir signal behind it, the PLC, which is increased. What is the evidence for minimally invasive fixation? This is a meta-analysis that was published in Global Spine, and the conclusion was that in terms of vertebral body height, kyphosis angle, and back and leg pain, there was no difference. Blood loss and operative time was significantly decreased in the percutaneous group, and that will represent a potential benefit, especially in the polytrauma setting. So some of the considerations for MIS surgery. 1, is there a need for anterior reconstruction? In which case, it can still be done MIS, for example, a MIS corpectomy, but it will probably be a staged procedure. The need for decompression, if you're going to use a tubular system for decompression, or you're going to do a mini open, sort of hybrid MIS open type of surgery. The need for fusion, and also whether the patient has got significant osteoporosis. So some of the tips and tricks to get a good MIS pedicle screw fixation: you can optimize the screw length and width, medialize the screw for improved biomechanics, and consider an index site fracture screw to strengthen the construct. And for osteoporosis, we commonly use cemented screws, but remember that implant removal then becomes not an option. For MIS, consider index site fixation. Use a shorter screw at the fracture site so that it doesn't interfere with the bone healing that occurs anteriorly. Aim downwards away from the superior end plate where most of the fractures occur. And you can side the fracture screw a little bit proud so that when you insert the rod, you can get the correction that is required. So what's the data for including the fractured vertebra? This is a paper from Rajasekaran's unit in Coimbatore, Ganga. And what is has shown that even in cases where the thoracolumbar fracture has a high load sharing classification score of more than, you can get away with not doing an anterior reconstruction by introducing a pedicle screw at the fracture site. Consider navigation when doing MIS. So I'm doing mainly navigated pedicle screw placement, and this allows for a very accurate placement of pedicle screw. With the O-arm, you can also check pedicle screw placement. You don't have to ever return to theater for screw revision. You can maximize the screw diameter as well as angulation. And I find it especially useful for placing index side screw. This is an example where we were navigating a screw through very narrow pedicles in Asian females. And we can do it with the help of navigation, and we can optimize instrumentation and biomechanics. This is some of my own data with the use of navigation for thoracic pedicle screw placement, as well as the routine use in the thoracolumbar spine, and our accuracy rates are in excess of 97 to 98%. What are some of the reduction techniques we can employ when we are considering a MIS thoracolumbar screw fixation? So positioning on the Jackson table is important. We can use monoaxial screws above and below the fracture level. We can use distraction or ligamentotaxis, but my recommendation is not to overdo it as it will impair the fracture healing. Index level screws can save the levels that are required in the fixation, and you can even do a MIS corpectomy for selected cases, as shown here in this imaging. MIS decompressions in a fracture setting can be technically demanding, especially when it occurs over the thoracic or upper lumbar spine. Over-the-top decompression is often required, and it might add significantly to operative time. And if there's a very severe fracture with CSF leak, that's also going to cause problems during the MIS decompression. Special considerations like osteoporosis, you want to consider using cement augmentation through the fenestrated screw. I would also consider teriparatide, which is a daily injection that has to be given before and after the surgery. For osteoporosis, I always do a longer segment fixation, and I can consider either anterior corpectomy or a vertebroplasty for anterior support. So in conclusion, MIS surgery has some obvious advantages over open surgery. Navigation pairs well with MIS surgery, especially if you are doing MIS surgery on a daily basis, can protect the surgical team and the scrub team from radiation exposure. MIS is not suitable for all fracture cases, and overall the technique should not compromise on adequate fixation, reduction, and decompression. If ever there is doubt, then consider doing it open. So back to the two CT scans that I showed you earlier. So for the very severe fracture dislocation type C, I did an open surgery. And for this A3, A4 type fracture, I did a MIS percutaneous fixation. And I think with that, I would like to end my talk. Thank you.
Thank you much. Thank you very much, Dinesh. The next speaker is Dr. Jacob O, who's an associate professor for one of our medical schools here. In addition, he's also the current head of the spine unit in Dang Lok Seng Hospital. He's going to talk to us on osteoporotic fracture fixation principle. Thank you very much, Jacob.
Good afternoon and warm greetings from Singapore. And to all my overseas friends, great to see everybody online and hope everybody is keeping well. I'd like to also thank the APSS committee for inviting me to speak at this meeting. Now, osteoporosis is no stranger to us, and it poses its own unique challenges to the spine surgeon. The bone purchase is poor, patients are frail, they might have comorbidities and an associated deformity as well. Not just at the fracture site, whether it's kyphotic, but also as a global sagittal alignment. Unfortunately, most of the cases can be managed conservatively, but about 15 to 35% of cases will require an operation. And for that, the spine surgeon has to be prepared in tackling this problem. Let's start with a case. This is a 59-year-old Chinese lady. She's diabetic, very small size, approximately 40 kilos in weight. She's admitted with lower limb weakness and back pain, which started after a fall in Japan. She was evacuated back to Singapore, and when I saw her, she had urinary incontinence and was unable to pass motion for about a week. Her BMD score was minus 3.2. Her examination was as such. She had a bilateral foot drop and bilateral lower limb weakness. She also had a lax anal tone with a reduced sensation and a PVRU and fecal. PVRU was high with fecal incontinence noted. These are her MRI scan and CT scans, which shows a T12 burst fracture causing compression in the spinal cord. And this is the level of the conus, and you can also notice that the bladder is very, very enlarged. And what are the indications for surgery in this patient? Well, based on the knee 3-column theory, this lady has a burst fracture and 2 columns are involved, and hence it's unstable and requires something to be done. Based on the German classification, this would be an OF type 4. Again, this needs a surgical intervention. And I'd like to introduce the classification popularized by Gabriel Liu. It's called the need for surgery, whether the patient has neurology, instability, or deformity. And this patient has all 3 of them. So we've decided that this patient requires an operation. So let's focus on the surgical fixation techniques on how we can help to manage this fracture better. So this lady has a T12 burst fracture. We know it requires surgery. And what we need to address is number 1, the kyphotic deformity, number 2, the decompression, and number 3, how to fix this using a stable construct. Some of the basic principles are we need to use larger screws, bigger screws, longer screws, and if you have an O-arm, the screws can be as long as possible. As you can see the picture on the right, that's one of my axial cuts on the O-arm. You can see the screws are kissing and it's almost touching the anterior cortex. Pedicle screw design also makes a difference, and some studies have showed that dual threaded screws also has a higher pull-out strength. We also like to triangulate our screws in the axial plane. If you can, under tap by 1 mm or even no tapping in some certain cases. Longer constructs, 3 points above and 3 points below, or 3 points of fixation above and below. And also engaging subchondral bone in the sagittal plane, for example, using the midlift screws. In the recent few years, cement augmentation has gained popularity, and for a good reason. It increases the pull-out strength by 2 to 3 times, and there are many ways to insert the cement. Some would like to use fenestrated screws like the picture in the middle that labeled C. It's easy. The downside is very costly. One screw can cost in Singapore dollars somewhere between $800 to $1,000. The more cheaper option, which is just as strong, is to first create a screw track, put a cement in and put a solid screw. Sublaminar wires and hooks are also a very good option, especially in osteoporotic bone, because the cortices of the lamina are much stronger than the marrow within the pedicles. Some people call this the pedicular laminar fixation, where in one vertebra, for example the L4, you put a pedicle screw and you also put a hook on the same bone, and it increases the pull-out strength by about 100%. Anterior column reconstruction is also just as important. As we know, majority of the forces run through the anterior column. And that's why, depending on the configuration of the fracture, you may decide to choose to put just cement inside the bone, the fracture site, or choose to reconstruct it altogether with a cage, so that you can limit the amount of posterior fixation from behind. There are other novel fixation techniques that has been described, for example, hydroxyapatite coated screws, expandable screws, using a double screw technique. I think these are very exciting techniques in the horizon, and I look forward to see more data on these. So let's go back to the case. This lady who had a T12 burst fracture with neurology, I decided to perform a T9 to L3 posterior instrumented fusion and a T12 corpectomy, 3 up, 3 down, strongest fixation with anterior column support. Spine was decompressed, and you can see I'm going all the way to the anterior, to the front. And these are the post-op x-rays. And here she is at 5 years. Her back pain has improved. She's not on any painkillers. She's continent with bowel and her bowel and bladder function. She's independent, and her neurology has improved to 4 out of 5, and her foot drop has resolved. She was treated with Forteo for 2 years as well. These are CT scan at 2 years, which showed solid fusion across the fracture site with good restoration of height. Well, I would be happy with that CT scan and her outcome. However, I would say spine fixation is not so simple. Otherwise, the talk would have ended right here. And the reason why I say that is because if you look carefully at her x-rays, you notice the red arrow points to something that we're all quite familiar with as well. Yes, that's right. She's got a PJK. Fortunately, she was fortunate enough that this did not have much sequelae, and it just remained stable over all these years. But that gets me thinking, I did this 5 years ago. I think my practice has changed. So initially, when we talk about orthopedics principles on dealing with osteoporotic bone, we always said, go big or go home, right? But in the spine, it's different. It's not a long bone. The spine has many mobile segments, and so if you put a construct that's too long, it becomes rigid and stiff, and it's prone to junctional stresses and adjacent level disease such as PJK. So going big is good for index problem, but are we creating a new one? I think this is how I see things now. You have an index level fracture and you want to fix it well, fix it strong. However, you must think about the level above and below to prevent secondary disease, secondary junctional problems. So how do I fix these fractures now? I add another component to my considerations, which is prevention of junctional pathology. So what is the ideal construct length? Well, if we go long, too long maybe, for example, the index case, it's good for fracture union and maintenance of correction. However, beware, this can be too stiff and risk PJK. So preservation of mobile joints helps to dissipate the stresses and creates less stress at the junctional areas, like this. And studies have also shown that if you extend the instrumentation down to the sacrum, it increases the risk factor for PJF by about 16%. If you go to a short segment, well, maybe less chance of PJK or PJF, however, is biomechanically less stable. And because of that, the short construct group in these studies showed there's more screw complications such as pull-out or loosening, and more loss of correction at final follow-up. So what is the ideal construct length? Well, if you look on your left, it is a higher risk of fixation failure and loss of correction if you go short. If you go long, it's higher risk of PJK. So perhaps something in the middle, or the sweet spot we call it. And there are many variations that work. For example, you can still go short, but make sure you augment it with either cement or anterior column support with a cage or cement in the vertebral body. A bit longer, using hooks and cement in the front, or a decancellation procedure or PSO to get the alignment correct. And this study shows that of all the types of procedures, comparatively, for example, anterior, posterior, front, back, with a vertebroplasty, with osteotomy, the conclusion is similar outcome in terms of complication rates and prevalence of mechanical failure. But I think what's important from this paper, it really depends on, you must tailor the type of procedure towards the severity and the configuration of the fracture, right? So it's very, very collapsed, then you need a cage. If it's not so collapsed, put cement. So Everything really boils down to each individual patient and the surgeon preference. But what's just as important, and I would like to highlight this, is you must respect sagittal alignment. Now, fixing long is probably not, it's a risk factor for PJK, but we fix long a lot of times. It's not uncommon. For example, deformity cases where we go L2 to S1, T10 to pelvis. And it's very important that we respect the sagittal alignment. Not just sagittal alignment, but age-related pelvic parameters. And for example, normal values, PI minus LL is equal to 10, is not the same for the elderly patient. Okay, and also in those patients with severe kyphosis, you may require an osteotomy because getting them in a neutral alignment is more important. Otherwise, they might go into junctional disease. And finally, in terms of post-op care, I like to use 4-2 if the BMD is very, very poor, at least for 1 year, and I brace these patients as well. In conclusion, I would say we've discussed the indications for surgery in osteoporotic fractures. The fixation principles have been discussed. Go use longer screws, bigger screws, cement, hooks, and anterior column support. In the spine, take it one step further. Consider about the index fracture, but also prevention of junctional disease. Okay, you need to balance implant loosening versus PJK based on the length of the construct. And there are many techniques described, but choose which one the patient needs and tailor it to the type of fracture configuration and the patient's age, deformity, degree of collapse, and whether there's neurocompression. And don't forget to respect sagittal alignment. Thank you very much, and I'm happy to take any questions.
Thank you very much, Jacob. And we would like to invite the APSS colleagues and then also to join us in the webinar, and then so that we can actually have a discussion. And then after all, we encourage the society to society interactions. So with this, I open the floor to questions, and then we have Dinesh and Jacob here, and we have Kenny and also Chek, and also we also at the background of the faculties. Feel free to jump in and talk about any questions. Yes. So while we are waiting for the questions, maybe I would just have a look, and then maybe I have a same question since we have Chek here and Kenny here. So while you're thinking about it, what is the proportion of MIS fixation are you guys doing for fracture, and what are the proportion of osteoporotic patients that you guys are facing in your respective country? But before we go to that, maybe I will just ask two questions, one to Dinesh and one to Jacob. And then Dinesh, and then you use a lot of MIS techniques and things. And then what are the advice? I mean, because some of the participants in this meeting, they may not have the O-arm, and some have the O-arm. So how do we reduce radiation risk if you do just the II fixation? And then that's one thing. The second thing is that if you use O-arm, sometimes you can only scan up to about 4 or 5 segments. And then do you scan how do we limit yourself in terms of the radiation now to the patients when you use O-arm? And how do you avoid radiation to yourself if you use II? That's the first question. And then for Jacob, in terms of the question I have is that your techniques on applying cement screw is going to be very, very important nowadays for osteoporotic fracture in adult deformity spine surgery and to reduce PJK. But cement leak is a problem. And how would you ensure there's no cement leak from your screw or maybe from your adjacent level? So without delay, Dinesh.
Yeah, hi. Thanks, Gabriel, for the question. I think there are certain newer technologies available, like the less ray system, which can help with using fluoro for MIS. It can help to reduce the dose required because of the algorithm that they have that can calculate based on the initial X-ray that was taken. Generally, try to avoid live fluoro shots. I know some spine centers very commonly do live fluoro shots. It's faster, but it will definitely expose the risk of radiation to the team. With regards to the O-arm question, if it spans too many levels. I think you can take in the thoracic spine up to about 6 to 7 levels. In the thoracolumbar spine, you should only cover about 4 or 5 with each spin. If it spans that, then you can actually do 2 spins, and you can stitch the image, and send both data sets together to the navigation system. So depending on which level you're operating on, they can just put up that particular data set. For trauma, you have to be a bit careful. If it's a very unstable spine, like in my talk when I showed the obvious fracture dislocation, navigation is sometimes going to be off because your reference array is going to be at one corner and the spine below may have moved already. So you have to sort of keep that in mind. It's not always accurate, especially in a very severe trauma type of setting.
Thank you very much, Dinesh. Jacob, how do you avoid cement leak in your cement screws?
Yeah, thanks a lot. I think that's for me. I use the O-arm quite a bit. So when I put the screws, so I want to make sure that the screws are not too long. If I go bicortical, the cement might leak out. So I like to keep it at the 3/4 line where there's still enough space for the cement to migrate out, but not out of the bone. I also make sure the cement is not too soft, not too liquid now. So I wait for about at least 9 to 10 minutes and then check the consistency. And I just put about 2 to 3 cc's. So that's my technique. And of course, I do it under fluoro. So every time a few mils that I insert, I always check the AP and the lateral to make sure I'm not having any breach. So I think these are the techniques.
Is there a particular, although we're not supposed to talk about names for implant, is there a particular system? So for example, there's certain system that when I use the cement screw, the pressure is so hard that you are literally very difficult to screw in the cement. The minute you screw in the cement, for sure you will leak to the lung, to everywhere else. I mean, is there any particular system that, or generally that there is no problem with you?
Well, I heard that other systems are different, but so far I've been using the same system, right. And I can relate to what you mean. After a certain time, because you don't want it to leak out, you're really pressing very, very hard, and you don't have much time to push it through, yeah.
Will do. Okay, so we'll open the same thing. I mean, in terms of distribution, your practice in Hong Kong, in Malaysia, and also maybe in India as well, and also in Pakistan. And then do you use now your practice is mainly MIS, and also what is your tips and tricks for osteoporotic spine fracture? Maybe we start with Kenny.
Thank you, Gabriel, for your question. So in a trauma setting, I do try to use MIS as far as possible. So only in obvious open cases where MIS is not possible, then I will use open. For example, there's a severe fracture dislocation that needs a concomitant decompression, things like that. But otherwise, I try to do MIS. For osteoporosis, it's not just in the osteoporotic fracture setting, but also very often now in our elective setting, we have these problems that we have to deal with. So I do use cement screws very often. One of the things we do is actually try to inject the cement a little bit earlier, so that if it's not as so as not to actually do it in a very hard pressure, but not too early. So in our system, the working time is 30 minutes. So I try to inject it after 10 minutes. So between 10 and 20 minutes is the ideal time for me. And I also use a screening and the AP and also the posterior to make sure it's not leaking to the back, and also hopefully not seeing a venogram as we inject our cement. So that's one technique. The other technique is maybe to reinforce it with some sublaminar wire to protect the screws. That's another technique I use. And also in very rare settings now, sometimes I may need to use a hook to also reinforce the screws. So for example, if you're uncertain about some of the screws that may become loose, you can also reinforce it at the same level with a laminar hook. And that's some of the things that we try to do. Obviously, all the things that Jacob talked about, using larger screws, longer diameter, etc., those are useful as well.
Thank you, Kenny. G-Kit?
Yeah, to address on the issue of MIS in thoracolumbar fractures, we mainly use MIS technique unless we need to fuse the segment if there is mainly ligamentous injury, or when we need to open and decompress the spine. So then we would use open technique. So to address one of the questions you asked just now, how to reduce, we don't use CT guided, we don't use navigation, but we use fluoroscopy guided MIS technique. So there are a few things that we can do to reduce the radiation. First is we usually do perform dual surgeon technique. So 2 person putting the screw at once. So 1 II shot, 2 trocar together. Second is we try to put, if we don't have issues, we try to put all the AP trocars, we use AP shots and try to put the trocars first. Then only on the lateral view, we can have 1 shot and advance all the trocars on the lateral view all together with 1 shot. So then these a few methods that we use to reduce fluoroscopy exposure. Yeah. So in terms of osteoporotic fracture, we mainly don't use instrumentation unless necessary. So in situation whereby there is neurological deficit, then we may need to have a more stable fixation. So then we will supplement with instrumentation. But most of the time we will use cement augmentation using by using cement vertebroplasty technique. Yeah. So when we use fixation, we usually use supplement with minimal invasive technique. So cement injection or cement vertebroplasty combined with MIS stabilization. And we will try to instrument as short as possible. Yeah. So
and just since the faculties are here and you all mentioned about cement screw, do you guys still use dye inject into the screw to see leak, look for leak before you inject the cement? I see Kenny is shaking his head already. Chiket?
Yeah, I don't use cement screw. So I use MIS technique without cement. Yeah.
Right. And then Jacob and Dinesh?
No dye, just straight to the cement. Yeah.
Okay. And then I see Professor Arif Khan is here as well. And then same question, what are your tips and tricks for your MIS screws, and how do you manage osteoporotic spine fracture?
Yes, so in our circumstances, it depends on whether the fracture is traumatic or non-traumatic. This is fragility fracture is non-traumatic or traumatic, and also whether it depends on we need to decompress it or there is normal neurology and we don't need to decompress it. So, for example, it's a traumatic fracture and we need to stabilize it and we need to do decompression as well. I will do an MIS fixation, but then at the point of the fracture with the vertebral body is located, I will open it up and do a decompression at that point. So instead of opening it all the way, I will just do in that particular to decompress it from posteriorly. Then depends on the level. For example, there's a fracture of T8, and if I'm doing a long second fixation, I may be ending at T5 or T6, somewhere where I will fear of PJK. So in that case, I would like to do a 2-segment up and down, and I would like to add anterior stabilization to it instead of doing and ending up in the middle of the thoracic spine and then ending up with PJK. So in that, I will do a 2-level up and down and aid anterior support to prevent the PJK in these cases.
Thank you very much. Back to Kenny. Thank you.
Thank you, Gabriel. Thank you, everyone. I would like to, on behalf of Vishal, the chairman of the online education subcommittee, thank everyone for attending the webinar. We have learned a lot about the controversies in the management of cervical spine fractures and dislocation and spinal cord injury, thoracolumbar burst fracture, And also particularly thank you to our guest nation, Singapore Spine Society, for contributing to the MIS fracture fixation technique and also osteoporotic fracture fixation technique. I would also like to take this opportunity to thank Nuvasive for supporting our online webinar series. And this is the last online webinar of this year. So please look out on our website for our future webinars, which will take place probably in January next year. And thank you all our faculties for contributing and for your valuable comments and contributions. And also thank you our President, Professor Rajasakharant, and also Chairman of the Education Committee, Dr. C.C. Wong, for allowing all these to happen. So thank you all. Hope you have a pleasant weekend and a nice Sunday. See you next time. Goodbye from us.
Goodbye. Have a good day.
Bye-bye.
Goodbye. Thanks.
Bye.
All right. Thank you very much.
Thank you, everyone. Bye-bye.
Yeah. Thanks, Kenny.
Bye. Bye, Chiku.
We have stopped recording live now. We have stopped recording and stopped live now as well, Dr. Neeraj. Yeah.
Yeah, it seems like it's still recording. Yeah, but okay. Thank you very much, Kaylin. Thank you, everyone. Bye.
Thank you so much, Chiu. Thank you, Dr. Neeraj. Thank you all. We have stopped live, I think. Yes, we have stopped live. Great, thank you. Okay. All right. Sorry. Thank you so much, Dr. Neeraj, for hosting and OrthoTV for hosting. I think that's all for the webinar. Is there anything that we needed to update before we close, before we leave the whole room? No, yeah. I'm not hearing from Dr. Neeraj. Okay. So yes, thank you so much, and yeah, take care. Have a good day. Bye.